Hello and welcome. Today, we're diving into a critical condition affecting the kidneys, renal infarction. We'll explore what it is, what causes it, how it's diagnosed, treated, and ultimately, how we can minimize the risk. Renal infarction occurs when the blood supply to the kidney is abruptly interrupted. This usually happens due to a blockage in the renal artery or one of its branches. Think of it like a stroke, but instead of the brain, it's the kidney that's being deprived of oxygen and vital nutrients. The most common culprit is a blood clot, technically called a thromboembolism, which travels from another part of the body, often the heart or aorta, and lodges in the renal artery. Conditions that increase the risk of clot formation, such as atrial fibrillation, heart valve problems, endocarditis, and recent heart surgery, are major contributors. Other less common causes include renal artery dissection, where a tear develops in the artery wall, or even external compression of the artery. In rare cases, kidney tumors or fibromuscular dysplasia, a condition affecting the arteries, can also lead to renal infarction. Let's delve into the pathophysiology. When the renal artery becomes blocked, the kidney tissue downstream is deprived of oxygen, a state known as ischemia. If the blockage persists, the kidney cells start to die, resulting in infarction. The severity of the infarction depends on the size and location of the blockage, as well as the overall health of the kidney. A large infarction can lead to significant kidney damage and potentially compromise kidney function. The kidney releases certain enzymes and substances into the bloodstream in response to the injury, which can be used to diagnose the condition. Over time, the infarcted tissue may heal with scar formation, further impacting kidney function. Renal infarction is considered a relatively rare condition, but its true incidence is likely underestimated. This is because the symptoms can be nonspecific and mimic other more common conditions. Studies suggest that it occurs in approximately 4 to 1.5 per 100,000 people per year. Individuals with pre-existing cardiovascular disease, such as atrial fibrillation, heart valve disease, or atherosclerosis, are at a significantly higher risk. Additionally, those with hypercoagulable states, which are conditions that make the blood more prone to clotting, are also at increased risk. Finally, people who recently underwent traumatic injuries, surgeries, or diagnostic procedures are at increased risk. The symptoms of renal infarction can vary greatly depending on the extent of the damage and the individual's overall health. The most common symptom, severe flank pain, often radiating to the groin or abdomen. Many people also experience nausea and vomiting. High blood pressure or hypertension is also a common finding. Less frequently, patients may experience fever, blood in the urine, or even a decrease in kidney function, which can manifest as reduced urine output or swelling. Because the symptoms can be vague and overlap with other conditions, renal infarction can be challenging to diagnose quickly. Diagnosing renal infarction requires a high degree of clinical suspicion and often involves a combination of imaging and blood tests. A computed tomography angiography, or CTA scan, is the gold standard for diagnosis. This specialized CT scan uses contrast dye to visualize the renal arteries and identify any blockages. Magnetic resonance angiography, or MRA, is an alternative imaging technique, although it may not be as sensitive as CTA. Blood tests can also be helpful. Elevated levels of certain enzymes, such as lactate dehydrogenase or LDH and creatinine kinase, or CK, may indicate kidney damage. Urinalysis can also reveal the presence of blood or protein in the urine. Electrocardiogram, or ECG, can be ordered if the doctor suspects the infarction is associated with heart arrhythmia. While there aren't distinct types of renal infarction, it can be classified based on the extent of kidney damage. A complete renal infarction involves a blockage of the main renal artery, leading to widespread damage. A segmental infarction, on the other hand, affects only a portion of the kidney, typically due to a blockage of a smaller branch of the renal artery. The severity of the infarction and the impact on kidney function depend on the size and location of the affected area. The primary goal of treatment for renal infarction is to restore blood flow to the kidney as quickly as possible. This is usually achieved through the use of anticoagulant medications, such as heparin or warfarin, which help to prevent further clot formation and allow the body to naturally dissolve the existing clot. In some cases, more aggressive interventions may be necessary. Thrombolysis, which involves injecting clot, dissolving drugs directly into the renal artery, can be effective administered within a few hours of the onset of symptoms. In rare cases, surgery or angioplasty, a procedure to widen the blocked artery with a balloon, may be required. Management also includes controlling pain, managing blood pressure, and providing supportive care to maintain kidney function. Long-term management often involves continued anticoagulation to prevent future clots and monitoring kidney function regularly. Preventing renal infarction primarily focuses on managing underlying risk factors, such as cardiovascular disease and hypercoagulable states. This includes controlling high blood pressure, managing cholesterol levels, and maintaining a healthy lifestyle through diet and exercise. Individuals with atrial fibrillation or other heart conditions that increase the risk of blood clots may need to take anticoagulant medications to prevent clot formation. Regular check-ups with a doctor are essential for identifying and managing these risk factors early on. The prognosis of renal infarction varies widely depending on the extent of the infarction, the timeliness of diagnosis and treatment, and the individual's overall health. With prompt diagnosis and treatment, many individuals can recover kidney function and avoid long-term complications. However, a large infarction or delayed treatment can lead to permanent kidney damage, hypertension, or even kidney failure, potentially requiring dialysis. Recent research is focused on developing more effective thrombolytic agents and improving diagnostic techniques to allow for earlier detection and treatment. Studies are also exploring the use of novel imaging techniques to better assess the extent of kidney damage and predict long-term outcomes.